Okay, well, let's go ahead and get started. Welcome to Medical Grand Rounds. I'm Bob Walker, Chair of the Department of Medicine. Uh, this is a very special day. Every year we have the annual Alice Hamilton Lecture, and it is put on by and really celebrates our division of now called Occupational, Environmental, and Climate Medicine, renamed with the addition of climate just this year. Given the importance, obviously, of that issue and our commitment to being a major player in that space. We have a new chief of our division of occupational, environmental, and climate medicine after spectacular tenure by Paul Blanc, who's now emeritus professor in this year. Our new chief, who some of you may not have met yet, is Gina Solomon, who is a world expert in all of the aspects of the division's title. And Gina will introduce the Alice Hamilton Lecture, and we'll introduce our speaker, and I will take questions at the end. Gina.
Thank you, Bob, and I'm so happy to be here to introduce our speaker for the 31st Annual Alice Hamilton Lecture. But first, who was Alice Hamilton? A lot of you may be wondering that, and I do want to spend a moment on that question because Alice Hamilton, who was born in 1869 and was still under active FBI observation when she was in her 90s, was a physician and leader in our field of occupational environmental medicine. She, as you could tell, was considered a bit of a subversive in her time. She was there weren't very many women in medicine, first of all, but then she focused her work on research into health issues that affected particularly poor and immigrant populations. A lot of her work was done in Chicago, where she lived in one of the settlement houses, Hull House, which was at a place where a lot of people congregated and worked together to address issues that affected the immigrant community in the inner city area of Chicago. And she did a number of studies on diseases such as tuberculosis and typhoid fever. And in the TB study, she discovered that a lot of that she found an association with where people worked, started focusing on workplaces and discovered that workplaces were rife with hazards, health hazards. She wrote on lead, she wrote on manufacturing explosives, explosive manufacturing workers. And that, was during World War I. She wrote on aniline dyes, carbon monoxide, mercury, radium in wristwatch dial painters, benzene, multiple other chemicals of the time, and that are still with us, unfortunately, many of these. And she also took her research and really moved it forward into policy and advocacy, which is, I think, an important aspect of our field of occupational, environmental, and climate medicine. And in that vein, our current speaker today, Dr. Robert Cohen, has in many respects, in my view, followed in the footsteps of Alice Hamilton, as many of us have tried to do in this field, inspired by her work. And I think it's appropriate to think about the history and the present day, because many of the diseases that were prevalent back in Alice Hamilton's day are unfortunately still with us. And this is true of the occupational lung diseases. And some of you may think, the pneumoconioses, coal miners, pneumoconiosis, silicosis, that those are diseases of the past, of the textbooks. But that is unfortunately not true, as you will hear. And Dr. Cohen is the director of the Occupational Lung Disease Program at Northwestern. He's also a clinical professor of environmental and occupational health sciences at the University of Illinois School of Public Health. He trained at Cook County and really has the Chicago roots and connection that Alice Hamilton walks those same streets. And his research has been focused on, as I mentioned, on occupational lung disease, but also in addition to leading projects studying injury and illness in mining populations, he also has taken that into the policy realm, working as medical director of the National Coalition of Black Lung and Respiratory Disease, working with the Mine Safety Research Advisory Committee for the National Institute of Occupational Safety and Health, working closely with the Mine Safety and Health, with MSHA, Mine Safety and Health Association. Oh, now I've forgotten. Administration, thank you. And also has worked to review mine disasters with the state of West Virginia. He also has worked internationally in Ukraine, Colombia, and Australia. And he also not only treats patients, but he also takes those lessons into the research realm and into the policy realm. And I think we're going to hear about all of that and in our talk, which I'm very much looking forward to, by Dr. Robert Cohen.
Thank you so much, Gina. Thank you, Bob. It is a pleasure and honor to be here in San Francisco for Grand Rounds, and really exciting to be an Alice Hamilton lecturer who is certainly a hero of mine and many of us in the field. So what I'd like to talk to you today a little bit, just these are the people that fund our work. I have no conflicts. I'm unconflicted. What I'd like to talk today about is the spectrum of diseases that's caused by exposure to these dusts, and give some examples, a couple cases and some examples of recent outbreaks of dust-related lung diseases that we just should not be seeing. They're entirely preventable, and it's just tragedy that we're seeing these things. And then I'll talk about some of the recent efforts to improve prevention of these diseases because they are 100% preventable. So we'll start with a tale of two countries, two cases. Patient IS was a 36-year-old. This is when I was at Cook County Hospital, was admitted with a 2-month history of cough, sputum production, and shortness of breath. Really no significant past medical history. Review of systems was just significant for the weight loss. For no weight loss, just his symptoms that he presented with. And he was a very relatively modest smoker and drinker. His occupational history that the internal medicine residents got, which was great, they even thought to say, what did you do for a living, which sometimes doesn't happen, is that he worked for 6 years in landscaping, and they stopped there. He was afebrile on exam and just had some coarse breath sounds. I'm a pulmonologist, so I love chest x-rays. You may remember chest x-rays. They used to be the form of imaging of the chest. We don't see them as much anymore. But when you look at this chest x-ray, you can see that this is not a new process. There's volume loss. The left main stem bronchus is hiked up. There's some chronicity here, but also it looks like there's some alveolar infiltrates. The lateral wasn't really very helpful. On CT scanning, which we love CT scanning, it shows that there is really extensive disease. There's some cystic changes here in the right upper lobe, and you can see my mouse, and you can see some more cystic areas and fibrotic areas, and actually some, as we get further down, some air bronchograms. It doesn't project incredibly well, but there's a pattern that's called crazy paving that we see on this chest imaging as well. And very chronic disease, you can also see the volume loss. His pulmonary artery is quite generous, indicating some pulmonary hypertension. So this is a pretty advanced, sick young man, 36 years old. So we saw him on the pulmonary consult service, and I happened to see him, and we actually went and got some more history. I find that when you take a history, it's often important to ask people, when was the last time you were well, not just how long have you been sick? He said he was sick for 2 months, but really the last time he was well was over 11 years ago. With shortness of breath and cough. And I think it's important to ask things both ways. And really this happened before he came to the United States. And then the last couple of months, he just got much worse. He was treated with intermittent antibiotics for pneumonias, and they didn't know what was going on, both in Mexico and in the US. So we decided to actually go down and get a real occupational history, which is more than just what do you do for a living, which is great to ask that, but actually to go back and ask things a little bit more. So he started working right after high school and began working for demolition companies in Ixtapa, Mexico, as an independent contractor till he was 30. But he described tearing down buildings, cutting concrete floors with a circular saw, no respiratory protection, and he was a demolition specialist. In the US, it's true that he was a landscaper, but his landscaping was the specialty of creating retention ponds, fish ponds, and cutting and shaping porcelain brick and artificial stone brick. He reported dry cutting this material with no respiratory protective equipment at all. This isn't his photo, but it's a photo of someone cutting this type of material, and you can see that it's generating a real nice plume of dust. It's respirable dust, and these guys that are working behind these saws are just right in that plume when you're guiding that saw through that material. His clinical course, he was HIV negative, serologies were all negative. We bronched him and looking for any infectious process, and it was negative for any infectious organisms. But we did send the fluid for lipoproteins and for crystalline particulate. We actually sent it to get scanning electron microscopy, which was positive for silica and silicate particulate in his fluid, which means there's a lot of that stuff there. So we thought he had acute on chronic silicosis, and this is, modern day Chicago. Because he was so sick, he was on high levels of oxygen. We did attempt whole lung lavage, which is not really very well proven for chronic silicosis, but if people have acute overwhelming exposures, some people think it might help. Didn't help him. We referred him for transplant because he was so young and so sick. They rejected him because he was undocumented, had no insurance. We often had this problem at Cook County Hospital where people were allowed to harvest organs from our undocumented patients, but we weren't able to transplant them. Something that we're still working on and maybe is a bit better, but it was really devastating for him and his family. So we loaded him up in a van with these large H tanks of oxygen, sent him home, and he passed away. Our second case, not quite as horrible and devastating, but still a sad case, was patient RJ. This is a 51-year-old miner, coal miner, with a history of an abnormal chest X-ray. And his doctors made a diagnosis of sarcoidosis in Australia, and they sent his chest X-ray to me for a second opinion. He had minimal symptoms of cough and some shortness of breath with heavy exertion. No other significant past medical history or review of systems. He came from the UK, went to Australia in his early 40s, and he had 27 years of smoking at half a pack a day. So also modest smoking history. And his occupational history is quite detailed, and this can be a difficult thing to do. You really need to spend time. What did you do when you first got out of school? What did you do next? And so forth. But he had was an apprentice boilermaker, which could have exposed him to asbestos. And then he was an underground coal miner in the UK. Some other jobs that were probably not significant for exposures. And then he was an underground miner in the Bowen Basin in Queensland, Australia, where he emigrated when the mine shut down in the UK. And this is his chest X-ray. So the docs in Queensland thought he had sarcoidosis, and they were just going to make a clinical diagnosis of sarcoidosis. I'm not sure they took the occupational history or cared that much about it. But you can see his chest X-rays got lots of round opacities, scattered round opacities, and areas where these opacities are kind of coming together into a larger scar. This is the CT scan of that larger scar in the left mid-zone, and you can see that it's forming a large opacity in his lungs. Just wanted to show you a little bit. His job was operating this device here. This is a longwall shear in an underground coal mine. This is not his mine, but you can see that this is the coal seam here, and above that coal seam is rock. In order to get the equipment into these mines, they often have to take a fair amount of rock above the seam so they can fit the shields and fit the equipment in. And rock contains respirable crystalline silica. And then the coal that they're harvesting also is coal dust with heavy carbon and not that good for you either. So as I mentioned, they diagnosed him as sarcoid. Queensland had decided that they had eliminated, even though they had 30,000 coal miners, they got rid of black lung in 1985. Just got rid of it. They announced that it was gone. So the Queensland doctor said, I can't diagnose black lung because it doesn't exist in Queensland. So that's where the sarcoid diagnosis came. They ignored this history and were coming up with other diseases. After we saw the X-ray, and I'll go a little bit more into this history, we did recommend that he get a lung biopsy. One is to prove exactly what he had wrong with him. And also he would undergo a fair amount of treatment with immunosuppressives if they thought it was sarcoid, and that we didn't think was appropriate. So we convinced the docs back in Queensland to do a biopsy, and lo and behold, with all his nearly 35, 40 years of coal mining, it was coal workers pneumoconiosis, and it actually was anthracosilicosis. There was a lot of silica particulate. So they found out that they do have black lung in Australia. Among 30,000 coal miners, they at least had one case, but of course they blamed that on the UK. They said it was his mining in the UK, not Aussie coal, that did this. So let's talk about how you make a diagnosis of these diseases and a little bit more into these outbreaks. So to make a diagnosis, the most important thing is that history of exposure. And that's the thing that we find tragically is missed so often. We ask people their genetic history. What did your great-grandfather die of, your grandmother? But we don't go into the history of what did you do for a living for all these years that you were actively out in the workforce. Then chest imaging abnormalities are really important. Nowadays, we still use chest x-ray, plain chest radiography for surveillance of large populations, but chest CT is really the test of choice. And one day we'll kind of race into the late 20th century and do CT scanning for surveillance, but we're not quite there yet. And then rarely do we get lung pathology and other laboratory tests for various immunologic occupational diseases. But this womb to tomb occupational history is important. Some people say sperm to worm, but that maybe is a little excessive on either end. But really, let's go very carefully and get every job that this person has ever had, and at least ask the question, have you ever worked in any job for at least 6 months where you've been exposed to vapors, gases, dust, or fumes? If they say yes to that, then you go to the womb to tomb thing, which takes time. So you'll have to tell your supervising doctors or your other people that are waiting for the next patient in 20 minutes that you've got some questions to ask. You want to ask, what kind of work do you do? But then you have to say, what does that mean? Because just because we're doctors, we really don't know what these terms mean. I'm a rib bolter. Somebody will tell me, well, I didn't know what a rib bolter was, but they're bolting the sides of the ribs of a coal mine tunnel, or all kinds of work jargon. And often my residents are a little shy, or other folks, to ask, what does it mean? Let them teach you, and you'll learn a lot. And so after they explain that, what does it mean? What are the exposures? Then what did you do before that? And you keep doing this until you get back to high school or whenever they left and went into the industry. So the pitfalls is the work jargon. Some workers don't know what they're working with. They're not educated by their employers. They may not have unions or safety committees. So they need to know the exact substances. Get SDS sheets, safety data sheets, try to get as much information as you can. And then in many workplaces, the workforce may not be very well protected, and they are afraid to tell you about this, and they fear that they're going to have reprisals or repercussions. And that's something we have to spend a lot of time educating them and reassuring them that it's confidential. We won't go back to their employers unless they give us permission. We really try to let them know that we're going to protect them. So pneumoconiosis, just to talk specifically about this disease, once you've got that history, you've got the chest imaging that we had in our cases, and you can make a diagnosis. Hopefully you don't need to go to pathology, but it's really just the accumulation of dust in the lungs, usually mineral dust, and the tissue's reactions to its presence. And those reactions can be more than just scarring. And I'll talk a little bit about the spectrum of diseases, because you may not think that these diseases can be caused by dust exposure when you see patients, but I want you to think about them when you do see them. The occupations that are at risk for mineral dust or dust-related lung diseases are all of these here, but basically anything that disturbs the Earth's crust, or anything where you're cutting, crushing, polishing, rock, stone, porcelain, anything like that. We had an outbreak of silica flour, silicosis in Illinois, where they're crushing, making flour that can be used, silica flour, to be used in paints and glues and different things like that. So in terms of this broad spectrum of disease, when we started thinking about this with coal mine dust, and that people just thought of coworkers' pneumoconiosis as a scarring lung disease. They didn't think of the range of types of diseases that it could cause. So we coined the term coal mine dust lung disease to make sure that people thought of it as a broader illness. But then we realized that it's more than just coal mines, it's any kind of mine. So in Queensland, when we were helping them write some legislation, they called it mine dust lung disease. But then we had all the workers with construction exposures. So we just call it dust-related lung disease, DLD. There's ILDs, but now there's DLDs. I want you to think about DLDs when you get workers that were exposed to dust. And that really reflects diseases from a variety of industries. And this range of diseases, you may not realize, is quite broad. There's the classic pneumoconiosis, which I'll show you some pictures of. That's the scarring lung diseases, where you get the tissue reaction of fibroblasts migrating into the area, macrophages trying to digest the dust and creating a scar that's either round or irregular. And then it can be many, many scars, and they get bigger and scar up the lungs. But also it can cause chronic obstructive pulmonary disease. And there is a thing of occupational COPD. everybody thinks of COPD and they only think of tobacco smoke exposure, but many substances can cause COPD that are in the workplace, and mineral dust exposure is one of them. And so you need to think about that when someone has COPD, even if they smoked, because you can have two things. You can smoke and you can work. Most smokers work. And when they work, they're exposed to that atmosphere. So we'll talk a little bit about that. There's a dust-related diffuse fibrosis that we'll talk about that's related to these, that looks like IPF, idiopathic pulmonary fibrosis. And we'll talk about that. And the silica proteinosis that my first patient had. I won't talk much about lung cancer. So these classic pneumoconiosis, this is a nice normal lung with a nice normal chest x-ray. So this is someone that, autopsy lung specimen. We don't usually do this as a test to get the lung from the patient. And this is simple coworkers pneumoconiosis here, or it could be simple silicosis if instead of being black, these little scars were pink and full of whorled collagenaceous tissues. They can be in low profusion. I'm not sure it projects that well in that x-ray. This x-ray is somebody with a moderately profuse disease. You can see lots of scars. And this is sort of like that coal miner from UK, Australia. And then you can have a real blizzard of scars that are present on the lungs in category 3 pneumoconiosis. And these are the standard x-rays we use to classify images for coworkers pneumoconiosis. And then there's this horrible stage of the disease called progressive massive fibrosis, which can start out with just one small scar here, but then you can get bigger scars. They're often symmetrical and polygonal in shape. And then you can get the entire lung, like this autopsy specimen or this patient in the x-ray, that's just replaced with these massive scars. And when I went to medical school back in the 20th century, we thought that we'd never see these cases, but it's incredible that in the 21st century that we are seeing them. And this is really quite tragic. Then there's this disease of dust-related diffuse fibrosis, which is often confused with idiopathic pulmonary fibrosis because it's irregular opacities. But the point is that if you have somebody with IPF, you must take an occupational history and make sure there's no exposures that could cause scarring in the lungs in this irregular pattern. And that's why if you don't take that history of the occupation, we call it idiopathic pulmonary fibrosis, because the physician didn't really go back and take that careful history to find out what might have caused it. And that's irregular opacities and causes diffusion impairment and restriction in the lungs. Here's a nice normal alveolus here. And then this is a person that has diffuse dust-related fibrosis. And we actually coined this term in that same article in 2012. We were thinking of calling it C. diff, coal dust interstitial fibrosis, but that was taken. So we decided to call it dust-related diffuse fibrosis. All right, we got to laugh there. And then the other form of the disease that you can get when you have really high exposures to silica is that you can get this silica proteinosis. The silica causes an outpouring of lipoproteinaceous fluid into the lungs. This is the X-ray appearance, much nicer X-ray than my patient that I presented at the beginning. But then you can see on pathology this really pink lipoproteinaceous fluid, and that's seen in acute silica exposure. But then you can get acute on chronic, and you can see this alveolar proteinosis. And if you see it in somebody with a lung disease, this is a coal miner's lung. And that's the normal lung there. And this area we're going to just zoom in on, and you can see areas in this really heavily scarred lung that show alveolar proteinosis. So for coal miners, we were seeing this a lot, and that made us think, especially in the miners we're seeing in the US, that silica was driving this horrible disease in US coal miners. So we call that mineral dust alveolar proteinosis, or MDAP. And we went and we stained it with PAS stain, periodic acid shift staining, and you can see that it's stained positive, proving that it was a lipoprotein and that this was a mineral dust alveolar proteinosis. So those are the classic pneumoconioses that we think about. But the thing I want to just mention a little bit about is COPD and emphysema and chronic bronchitis, because these dust exposures, silica and coal, and even asbestos, can cause airway damage, airway inflammation, and emphysema. There's a lot of data on chronic bronchitis and coal dust exposure. Cross-sectional studies and longitudinal studies have shown a relationship between the symptoms of cough, sputum production, shortness of breath, and exposure to dust, either in years or cumulative exposure if they had actual measurements that they could calculate over the worker's entire lifetime. And certainly cigarettes are not good and cigarettes cause this, but it seems like the effect is additive, that these dust exposures, a year of underground mining, a pack year of smoking, are relatively equal in terms of their potential to cause chronic bronchitis or emphysema. And then if people have bronchitic symptoms, they are more likely to have lung function impairment related to their dust exposure. And the other thing that's interesting as compared to cigarettes is that these mineral dusts and the lung function impairment may continue after exposure ceases. When you stop smoking, generally, the rate of decline of your lung function tends to go back towards a normal rate of decline. But with these dust-exposed patients, that dust remains in the lungs, the inflammation continues, and they may have progression absent further exposure. So we'll talk a little bit about emphysema, one of my favorite diseases, and mineral dust. And really, mineral dust is a potent cause of emphysema. And there's lots of studies, many of them were autopsy studies. They found that the emphysema correlated with the amount of dust in simple foci in the lungs, and that cumulative dust exposures correlated very well with emphysema severity. And I'll show you one important study on that. And dust exposure and cigarette smoking were similar in terms of their predicting emphysema and their toxicity, their relative toxicity. This was a landmark study done by NIOSH investigators and people from West Virginia and published in actually the cover page of the Blue Journal, the American Journal of Respiratory and Critical Care Medicine in 2009, where they took autopsied 722 miners, took a nice deli slice of their lungs, a Goff section it's called. They fixed it and then they sat and calculated how many holes in the lung there are. We have many more sophisticated ways of doing it on live people today with CT emphysema scores. But what they found is that there was they had non-miners and miners, and that the never smoking non-miners had a baseline score of about 50 of severity, but the smokers had 3 times that at around 150. The never smoking miners had a score of 300, 6 times that of the never smoking non-miner people. So that the coal dust in this population really caused a lot of emphysema. And for ever smokers to smoking miners, it was maybe twice that or 2.5 times that. Basically showing in a very elegant study that coal dust is a very potent emphysemogenic agent. And that it's important and it's not trivial compared to cigarette smoking. We're still working in many countries in convincing the coal industry that coal dust is a problem. They think it's all smoking, but it is a problem. And then when you add up chronic bronchitis and emphysema together, it really results in lung function impairment. And there's no doubt that exposure to coal dust relates to deficits in lung function as measured by vital capacity and FEV1. And these deficits occur even if you don't have scarring. So you can have the scarring lung diseases, or you can have the airway and emphysema diseases, or you can have both. But they can result in lung function impairment that correlates really well with the amount of exposure. And the risk factors for developing these dust-related lung diseases make sense. If you have an increasing concentration of dust or duration, for coal, the higher the carbon content, the more metallurgic the coal is, then the more toxic it is. And we're getting away from thermal coal these days because of climate change, but we're never going to get away from metallurgical coal, or at least as long as we need steel. It's needed for steel. And that's a very toxic dust. And then working in enclosed spaces, underground miners, artificial stone fabricators, and so forth. And this is an example of a very narrow space, underground miners, and they still work in these conditions. That's a bit of an older picture, but I took this picture in Jacksboro, Tennessee, of a U.S. coal miner changing the bits on a continuous miner head. And you can see that the space is quite low, certainly about less than 4 feet high. And when that thing is turning, it's generating dust really very, very quickly. With modern, powerful mechanical mining equipment, as you saw in that long wall picture, you can really generate dust quite well. So while we're having huge increases in production, we're producing dust and we're producing disease if we don't protect our folks. And this is a colleague of mine in Shanghai, China, Chest Hospital there, sent this picture of, but you've got great pictures from LA. Bob Harrison can share a bunch of information that their team has been looking at in California. People are working in very enclosed spaces. So high concentration, very enclosed spaces. I think this is almost like an exposure chamber. If you want to take somebody and see if we can expose them to silica, see what happens, this is not a bad way to do it. I say that somewhat tongue-in-cheek. So let's talk now about preventing these dust-related lung diseases, which is really a very, very important thing. And prevention, you probably all know this, but we have primary prevention, secondary, and tertiary prevention. The most important thing is primary prevention. That is reducing the exposure to whatever the toxic substance is in the workplace. Get rid of it, change it, substitute it, protect the workers from it, get it out of the atmosphere, engineer it, and reducing that exposure. Secondary prevention is medical surveillance. And this is where I've spent a lot of my life as a researcher and as a public health person, and making sure that medical surveillance of these exposed populations is good, that it's done well, and that the data is analyzed. It's wonderful if you diagnose somebody with early disease, you can mitigate the exposure, get them out of the exposure. But if you don't collect that data from these workplaces and feed it back to a central public health agency to look at, you can't control the sick workplace. You got a sick patient, but you also have a sick workplace, and that has to be taken care of as well. So secondary prevention, two purposes: take care of the individual, get rid of the bad workplaces. And tertiary prevention is where we all here live and work, taking care of people who are already sick in the hospital, diagnosing them, treating them if we can, rehabilitating them. And then one of our things that we do is help them get compensation, help them get what they need to live if they can't work anymore. So let's talk about this epidemic of acute and accelerated silicosis. My guy was a landscaper, but he was working with a product that was very high in silica. And artificial stone is a substance that's really been in the news quite a bit. And it's the most recent epidemic of this ancient disease. It's composed of 90%, or many of them up to 90% silica. Don't you think somebody would have thought that cutting, polishing, grinding, fabricating this material could be a problem? But it seemed that that wasn't thought of. So we have that most recent epidemic. There's cases now reported from all over the world. US, Spain, Israel, Australia, and China have been prominent in the medical literature, but the cases are likely in the thousands. And they're really taking place in vulnerable populations, immigrants, undocumented workers, and in all of these countries, not just in the US. So it was first reported out of Spain. In Cadiz, they described 3 cases only in 2009. So really just 15 years ago. And then they reported another series of 47 cases after that. They all manufactured and worked with this material at home, these kitchen bench tops, bathroom tops as well. They were young. These folks are young. For 33 years is the median age for the Spanish folks, but they had a prevalence in exposed workers of 20%, 1 in 5 people developing this disease. And these were small family-owned businesses, non-unionized, really mom-and-pop operations. It's not the big employers that make this material, but it's the installers, fabricators that were getting this. And really short tenures, 11 years. That's short for these dust-related lung diseases. And they had horrible dust control, lack of education, no protective equipment. Dr. Blanc was involved in this report of artificial stone silicosis from Israel, and they reported 25 cases to the transplant service. That's not where we want to be doing our medical surveillance for occupational lung disease, catching them when they come to lung transplant. But that's what happened there, which is great that they noticed it. I really think that the transplant physicians should be commended for that. But they also were exposed to dry cutting, and this is 2012, and working hours, 10 to 12 hours, and also somewhat shorter duration of exposure. 10 of these 25 cases were transplanted, so that's how severe the disease is. When we were in Australia doing some of our work on black lung, there's also an outbreak in the Gold Coast, just south of Brisbane, and then also in New South Wales and Victoria. This is a series of patients from all of those 3 states, and they were not detected by surveillance at all. They were only detected when they came for care when they were very sick to specialists. They're also relatively young, doing the same thing for small corporations, and 7 years was the median exposure, dry cutting all the time. So this was in 2018. The Queensland government at that time responded by banning dry cutting immediately. So that was, they really snapped into action because of the other outbreak that I'll talk about among coal miners. And then Bob Harrison, Cecile Rose, Amy Heinzerling, and others published this MMWR in 2019 of the 18 cases that were reported in 4 states in the United States So we have this here for sure. This was back in 2019. And OSHA, federal, and then state OSHAs have actually acted very quickly. And Cal OSHA actually passed a rule against dry cutting in 2023. So it took them 4 years. The Queenslanders did it in shorter time, but still they did it. And that's really good. And I think Bob Harrison and all the colleagues that worked with him have really been instrumental in that. And then they instituted this rule. And I just got an email from Bob that 2 days ago, CBS Morning in LA reported that they've shut down some shops that were doing horrendous dry cutting and not taking care of their workers. So they shut down a number of operations. We'll have to talk about what the implications of that are for the workers, the workforce. Will this go underground? What will happen? But anyway, making sure that you close down places that are not doing the correct engineering controls. Dry cutting just means you aerosolize all this respirable dust very quickly into these exposure chambers that are these shops or even inside people's homes. I had a picture of a worker inside a home fabricating an artificial stone block with plastic over his head and over that material, basically to keep the apartment that they were working in free of dust. But you can imagine what that worker was exposed to. So one thing you can do is to ban a dangerous material. That's another that's one of the great things, or get rid of a material, substitute it in our hierarchy of controls for exposure in the workplace. So the Aussies did this last December. They banned artificial stone, which for them meant anything that was more than 40% silica in the country. That will go into effect in July of this year, July 2024. So I think that was pretty good, and I think not sure if it could ever happen here, but Safe Work Australia, in conjunction with all the Commonwealth states and territories there, banned it. So we need to substitute it, get rid of it. If we're going to have it work with something that's dangerous, we need to engineer it out of the atmosphere so that the worker is not responsible for that, but the engineering controls take care of it. And the last line of defense is a respirator. And you see these guys wearing respirators, but they're really hard to wear. You can't cough, you can't talk, can't spit. So it's really a hard thing to wear personal protective equipment and depend on that when you can get rid of the material or engineer it out of the atmosphere. So I'd like to talk about our second case and that situation, the coal miner from Australia that was diagnosed as sarcoidosis. This is Australia. Queensland is one of the huge states in Australia with a massive amount of mining, 40,000 active coal miners. We have less than that in the United States for the entire country. And this little dot is Moranbah, which is the Bowen Basin, their main coal mining region. This was an article published by US NIOSH reporting on the elimination of coal workers' pneumoconiosis in Australia. So the NIOSH engineering department, that is the NIOSH mining out of Pittsburgh, thought it was great that the Aussies got rid of black lung. They said, we should do that too in the United States. And they published this and said, the Aussies just said, well, we have just great controls. Our dust levels are wonderful. We have no disease. But they actually had just eliminated surveillance instead of eliminating the disease. And if you eliminate surveillance, like when I was a medical student, we used to say, if you don't take a temperature, you won't find a fever. You don't have to do blood cultures, urine cultures, all that stuff that you have to wake up for. And therefore you have no disease. Well, that's kind of what they did there. So they had a myth that they'd eliminated black lung. They had a review and they decided that it wasn't a problem. So they just made their surveillance into fitness for work, which means they took an x-ray and then the company doc looked at it, but they didn't submit it anywhere. No one reviewed it. They did spirometry that I call ceremonial spirometry. It was, the ceremony of taking a deep breath and blowing, but it really wasn't the real deal. And they actually had a cargo container on the airport in Brisbane full of all these chest x-rays. And that's why, and they had no central data, no capturing of information. So that case that I showed you, the United Mine Workers had a convention in Vegas. The Aussie mine president was here, mine union president was there, and showed me those x-rays, and a bunch of them were similar. All these cases of sarcoid, which were really co-workers' pneumoconiosis. And after that biopsy was done, and then people realized they had cases, the dust hit the fan in Australia. And this is the Daily Mercury in Mackay, Australia, with my picture. Thank you. And my mother wants to know what went wrong. But this basically was detailing this incredible failure on the part of the union at that time. Was, how could they believe that no one had even a 1/0 case or a very early case? The industry, certainly, government regulators, the societies of medicine really dropped the ball as well, including the colleges of occupational medicine. It hit the news there, ABC News. They found a catastrophic failure because there was a lot of disease there. This is 2017. My team and I, we went underground in Australia to prove that there was coal dust. So this is a picture showing that we went underground and we got dirty. And then the parliament had a parliamentary investigation in the state government, and they issued this report, Black Lung, White Lies, which basically showed that they didn't have surveillance. No one knew how to read x-rays. No one was looking at anything. And the Australian federal government had an investigation as well, their Senate Select Committee on Black Lung. And their summary said that, Black lung is preventable. They quoted me saying the number one thing is to mitigate and control the dust. But I thought that the miner that had black lung said it best when he said, if I had found out then that I was going to be like this, I would have got out of the mine straight away. It has buggered my life. And I didn't know what that meant at the time. It's not a good thing to have that happen to you. But I think only in Australia would they publish a report with that kind of terminology. I don't think you'd see that in a US Senate report. So since that time we worked with them, they didn't have any B readers or people that are trained to classify x-rays. We classified 65,000 x-rays from Australia, and we taught people, we had courses, we trained radiologists. Now they have really a world, I think a state-of-the-art program for surveillance in Queensland. And that happened just when this artificial stone hit. So they had all the x-ray capability, all the B readers. It was really very fortuitous. Last week I was there, and then I couldn't believe that Western Australia Chief Inspector of Mines got up and said that they got rid of x-ray surveillance in Western Australia. In Australia, by the way, each state is a different country almost. They have entirely different rules and many different things, but they got rid of x-ray surveillance. They've only done low-dose CT by the employer. No one else reads it. No central data collection. And he presented this a week ago. So I think we're going to have to find out what Perth is like, because it seems like a nice city. We'll go there and see if we can help them out. So to conclude, I think that these failures of public health surveillance, these failures of primary prevention, that they have to work together. The Queensland people showed us dust data showing wonderful compliant dust sampling, but they weren't doing surveillance. The dust sampling was done all by the industry, and there was no secondary inspections or controls on that to see if it really was working. If you don't have surveillance of the population for the disease you're trying to prevent, you may not be preventing it. And that's really what the case was there. That's why both primary and secondary prevention work together. So dust-exposed workers may develop diseases other than the classic pneumoconioses. I want you to remember COPD and remember emphysema. You got to take this detailed occupational history with details of job tests and dust control measures. It's critical to understand the disease risk. Chest imaging and physiologic evaluation are the key methods for surveillance. I would say we should start doing low-dose CT and perhaps more advanced physiology, including diffusion testing, in my opinion. And surveillance data provides a critical feedback to primary prevention. These diseases are untreatable. Transplant is not a therapy. You're exchanging one disease, one chronic disease for another one. And therefore, primary prevention should be the mainstay. And I want to conclude by saying that you should all think of yourselves as public health officers, that you're not just internists taking care of individual patients. You got to have a high index of suspicion for these diseases, recognize it, and take good occupational environmental history. And then think about that you should help with benefits counseling and legal referral. But again, this idea of a sick workplace, that you would be key. These may be sentinel events that you're diagnosing. So report them, get help, get consultation, because you may be the first line person that sees these folks and discover either an old disease or a new one. So this is my picture from Ukraine, which is now controlled by Russian militias and Russian forces. But underground, they would have two little metal tags. You leave one metal tag on the surface. You take the other metal tag with you when you go underground, and it clocks into that little box, and they have a toast every day. At the end of each day, your two tags should come together. You should come out of the mine alive. And so they drink a fair amount of vodka with that. But I would also add to that, you should come out of your career alive and healthy and safe if we can prevent these chronic diseases. That's the light at the end of the tunnel, and I thank you and take any questions.
Thank you. That was great. You said at the end, transplant's not a treatment, but why not?
It's not a solution. It's
But actually, I think we may need the mic there. I mean, it's true.
It's true.
It's another disease that you trade off
Right.
for whatever the cause of transplant is. Is there something about these kinds of lung diseases that are particularly not amenable to transplant?
We have transplanted these patients. Their mediastinum are in stone. So they have to chisel out the mediastinum. They're tough to do. They can do them. I really meant to say that's not a panacea that people say, I'll just go get a new pair of lungs, after these ones are worn out. So I was being a little facetious, but you are exchanging, the median survival is maybe 5 to 10 years. It's not great. And then you are in the hospital getting bronched, and it's a exchanging one disease for another.
Okay.
Yeah.
Any theories about why cigarette smoke, the progression seems to stall out if you stop smoking, whereas these don't?
I think what people think is that the particulate cigarette smoke is more of an aerosol, that stuff doesn't reside in the lung and stay in the lung. These dusts they reside in the lung, they stay there. So not everybody progresses, but you'll find the dust in the lungs. You can see it pathologically. You can see it on scanning microscopy. So that inflammatory process persists.
And in terms of the absence of any effective treatments, I assume things have been tried, and now there are drugs that we use for interstitial lung disease that seem to at least slow down fibrosis. Have those drugs been tried, and is there a reason that an antifibrotic drug wouldn't work, and if this is the instigating factor?
Well, the in-build trials that have shown, like nintedanib and other drugs for collagen vascular-associated interstitial fibrosis, have been useful. So we are encouraged. We had a pneumoconiosis trial with nintedanib that just went online just prior to the pandemic. So we haven't completed it. We will try them, but we don't want to be therapeutic nihilists. I think we need to try everything that we can, but certainly our focus should be on prevention. But these folks that are already sick, we should do everything that we can to. Pulmonary rehab is not that accessible, not that widespread, and provides a huge benefit in terms of survival and quality of life. So those things really we need to implement. But nintedanib, I think, is the next step that we had a trial out of WVU again that was stopped because of recruitment problems.
And then the screen, you said screening is really important. It would seem like if spirometry or something like that would work, it would seem to be relatively easy thing to implement. Does it work, or is it not sensitive enough? Then you really need the X-ray and or the DLCO or other more fancy measures.
That's a great question. I think that spirometry is one of the mainstays. The important thing to do with spirometry is to make sure that office-based spirometry and spirometry, it's very hard to do well. So in Queensland, for example, they have a full-time respiratory scientist that goes around to every clinic, checks them, teaches them. You've got to have very, very good training and continuous education, and you have to have central data collection. NIOSH, for example, collects spirometry electronically, all the data points, and they can review it. And you have to have access longitudinally, because you can go from 120% of reference in a healthy worker, go down to 80% of reference, which may be around lower limit of normal, and you've lost a third of your lung function. So if you don't have access to longitudinal data, which many places don't, they just do one off, oh, you're still normal. That's really key. And then diffusion would be great to add. And I think you need all of them, because you can see emphysema before you see some impairment, and some of the early interstitial changes may not show up. It's a bit of a blunt tool.
All right, let's open it up. Yeah, and say who you are. If you have a question, John.
John Bowles. Do you want this?
No, it should take it up.
Great talk.
Australia with co-workers pneumoconiosis, black lung disease. But you've also been very active in the US. And I don't think you had a chance to talk about how bad the outbreak of progressive massive fibrosis, severe co-workers pneumoconiosis in this country. So maybe a couple words about that.
Yeah, I was trying to keep it to 45. How many disasters can you talk about? No, but actually in the United States, there's been a terrible outbreak of severe co-workers pneumoconiosis with progressive massive fibrosis that's been epicentered in central Appalachia in the states of Kentucky, Virginia, and West Virginia, which is also, since the late 20th century, maybe 1996, we've seen hundreds and hundreds of cases of progressive massive fibrosis out of black lung clinics in Western Virginia, that Appalachian part of Virginia. Stone Mountain is one of the areas, St. Charles, Virginia, and then Eastern Kentucky is horrendous. And it's all because they're mining very narrow seams, and they're taking a lot of rock above and below the seams. And our surveillance program, while it's pretty good, is voluntary. And these workers, the union is only 12% unionized in the mining industry. So many workers are very afraid to participate in surveillance. They'll also, if they're identified with disease, they get fired quickly or they lose their jobs. And these are well-paying jobs. Guys can, put their kids through college, and men and women can. And so we've been working very closely with the Mine Safety Health Administration in the United States to change the rules for exposure to silica. And I didn't show that particular thing, but MSHA has just proposed a new rule. We hope it'll come out this spring. And the data from our group showing silica driving this epidemic in the US has helped MSHA to do this, but many others as well. So we're really hoping that will become a new regulation before the election. Otherwise, we're dead.
Miners are
We're not going to go there. When you say it's voluntary, is that a decision that is made at the federal level, or is it a state by state or a company by company decision? How does that get determined?
Well, coal mining in the United States it's really a wonderful thing that it's the only federal surveillance program for a workforce that exists. And it's mandated at a federal level that you get an exam before you start work and then 3 years after work, but then it's voluntary. And part of the reason is the union was concerned and they did not agree to make it mandatory. In Australia, it's mandatory, which is why their system now is so good. Everyone has to have it. They just didn't look at it and didn't collect the data, but they had to have it. Now they do that. But in the States, only 30 to 40% of miners that are actively working participate in surveillance. And then we find them all when they retire. They retire, they come in and get examined, and we say, this all should have been prevented. So that's a huge problem with our surveillance in the United States.
Yeah. Hi, thanks for the talk, Bob. This is Jim Seward. You mentioned CT in the context of surveillance, and obviously that's somewhat more expensive than plain chest X-ray or spirometry. Do you have any suggestions for how to incorporate CT scanning into the surveillance process? What the criteria might be?
That's a great question. And we used to say that there was too much radiation and too expensive. But now that radiation dose is coming down, the cost is coming down. And so low dose CT scanning probably is an option. It is still probably more expensive and not quite as portable as chest radiography. And the classification system, there isn't an International Labor Office standard system for interpreting it as there is for chest X-ray, but that can be fixed. So it's coming. It's late 20th century technology, so we should be there. And I think it is much more sensitive. The other thing is they're doing it in Western Australia, but as I mentioned, only sporadically. And there is a thing in Australia on a van, on a truck, that has a CT scanner that does go out into the bush, and they do it. So it can be done. They had to trial it with all kinds of sensors to make sure that the motion wouldn't destroy the scanner. And Philips Technologies worked with them, and they've got one. So I'd like to get it here, but it's expensive. Those are the issues with it. It's still a bit expensive, and we'd have to figure out how to get paid for it.
So I'm not an MD, and this isn't something I'm deeply knowledgeable about, but when I ask people about dust exposures locally, I'm much more likely to get people talking about grain dust exposures and flour exposures. How do the diseases cause, just, between silica and coal versus grain, how do they crop up very roughly?
That's a great question. Mineral dust tends to cause more of the scarring lung diseases, but grain dust has been associated with COPD for sure, chronic bronchitis symptoms, lost lung function impairment. And then with grain, depending on if it's got moldy or moist, you can get hypersensitivity pneumonitis, which is a scarring lung disease, farmer's lung. But grain that's clean can still, and there's silofilers diseases and a few other interesting diseases, but certainly COPD, lung function impairment, chronic bronchitis.
Thank you.
And just, you mentioned that in those diseases, it's sort of an inflammatory reaction. I'm guessing in the disease you're talking about, is there an inflammatory component, or it's just in there and fibrosing?
It's inflammatory to begin with, but then you get the release of these noxious polypeptides that will draw fibroblasts in. But it really is interesting on whatever the host susceptibilities are. Some people go the fibrotic route. Other folks go with airway damage, airway inflammation, and emphysema. And depending on what your own individual susceptibilities are, you may develop one or the other, or often both.
And do we know anything about individual susceptibilities? In that, I assume you can have two people with the exact same exposure, one gets it and one is fine.
That's exactly right. As you have with smoking, we all know people that smoke 90-pack years and they're fine, and then someone who smoked 20-pack years and has horrendous disease. So certainly protease deficiencies like alpha-1 antitrypsin deficiency has been shown, I think in Scandinavian series that people who never smoked but were working in mineral exposed jobs or dusty jobs would get emphysema. So that susceptibility, but other susceptibilities, people are still looking at the genetics and of that.
Ramon Terrazas, Dr. Cohen, thank you very much for this very stimulating talk. Going back to your case about the miner from Australia, if there was a need to know, would it be possible, based on the structural signature of the silica or the radioisotope signature of the silica, to pinpoint where he got his silica? In other words, is there a difference between Australian and UK silica? And then fast forward to manufactured stone, would it be possible, based on the composition of the silica, to trace that silica to a particular manufacturer?
It's an interesting question. I was asked that by the attorneys for this patient in Australia because they were trying to sort out which coal company was going to be responsible for paying his compensation. I think that I don't know the answer if there's a different, radioisotopic signature to silica from one place or some mineralogic or geologic way of telling. Generally, there's variability in the percentages of silica or quartz. It's silicon dioxide. And I don't know that you can really, and likely he had both. I'm sure he's got dust from his time in the UK. It would be impossible for me to believe that he had only dust from the UK and nothing from Australia. His X-ray was relatively normal when he came to Australia. It was, I saw like a 1/0, but then he had those years where the conditions were pretty intense. So I'm sure he had both. But I don't know of any way pathologically, mineralogically. But we do see differences in the percentages of silica in the geological strata. And so we can see, and silicates. And so there is some aluminum silicates, aluminum potassium silicates, other materials that are in the dust that maybe you could do such a thing. But I haven't seen data on that in particular.
Bob, thank you. This is Bob Harrison. Great talk. We've been tracking these cases in California from the artificial stone fabrication workshops. And recently, Orange County, which is one of the larger counties in California, notified us of, I think, 4 cases that have been treated in their TB clinic in Orange County, which they realized also actually have silicosis after taking an occupational history. And I know you didn't have time to cover everything today, but maybe you just want to comment about tuberculosis and autoimmune diseases also in conjunction with silicosis.
I'm glad we have a lot of ringers in the audience to ask me these wonderful questions. So there is a thing called silicotuberculosis. Certainly, silica poisons macrophage or reduces macrophage phagocytosis and capabilities, which is really important in cellular immunity for mycobacterial infections. Plus, these workforces used to be underground, close-spaced, and so they could transmit the disease. And they also lived in mining camps, like, for example, in South Africa, where people were also housed. And there's epidemics of silicosis, epidemics of silicotuberculosis. And then, of course, we threw in HIV, TB, and silica as well. But it's much harder to treat because silica does cause impairment, and we treat longer. There's not great randomized controlled studies on how long to treat silico-TB. I've got one guy right now I'm treating. He's been 18 months, and he's finally getting better. But and then the other question is collagen vascular disease, which is really common. And Dr. Blanc has done a lot of work on this as well, especially with silica exposure, where people have higher rates of scleroderma, higher rates of rheumatoid arthritis and arthritis in general. And so I'd refer you to some of the work that Dr. Blanc has done. But it is certainly we've been doing a lot of serologic screening in our chronic exposed, silica exposed populations, and very high rates of positive ANAs and so forth. So definitely a confounding disease or another disease.
Maybe last question. You could argue that perhaps the most important industry in the world now is using silicon for chips. You didn't mention that as a risk factor. Is there something about that manufacturing process that's particularly safe, or is it a different chemical?
Well, it's not a dust. It's not really people that are digging it out of the ground, grinding it up, making silica flour, silica paste, but it has to be aerosolized as a dust to cause a problem. People would often ask about, silicone breast implants or other things like that, but it has to be respirable crystalline silica for these diseases, RCS. We hate it. We want to control it. We want to substitute it, get rid of it, whatever we can do.
Thank you so much for a terrific talk, and thank you for visiting. Appreciate it.